or underground mining combined. That's crazy when you think about it. It's safer to go build a building or dig for gold under the ground than it is to be a nurse in the US. So there's a huge push to make things safer in healthcare. And one of them is getting rid of sharps. If you don't need to use a sharp, don't use it. Now, moving on to INS, the Infusion Nursing Society. The beautiful thing about this set of standards for nurses is it gets very specific. It tells you how to do the procedures. The CDC gives you the general overview, but it doesn't tell you actually how to do it. INS tells you the specifics. It's nursing focused. Now, INS talks about an ESD, or an engineered stabilization device. This is a new set of language. We see in all the new studies coming out is nobody talks about securement anymore. They talk about stabilization, an engineered stabilization device. I'll go more into the differences there later on. But basically, stabilization is wiggling, securement is gross dislodgement. Now, what's interesting is ESDs, engineered stabilization device, promote consistent practice. As you know, as you practice, there are new nurses, there are experienced nurses, there's ICU nurses, there's labor and delivery nurses. They all practice at different levels for different things. And when it comes to vascular access, infusion therapy, which is something that every nurse in the hospital shares, we all do it a little bit different. And with an ESD, it promotes consistency. You have a device, one device that is used one way, gives you one level of performance. So it's a way for nurses to, I guess, regulate the performance of their outcomes. Now, they also help to reduce the interruption of the care. As you know, when you lose an IV, it takes time. It interrupts the care. There could be other complications. And also associated with that are increased costs, which most hospitals don't really think about, are the costs associated with the delay. If you're, delaying the treatment, number one, if you lose a catheter, the price of it, the hospital has to pay for it, they don't like, administrators don't like, and then your patient's in there for longer, it can add up. Now, with central lines, sutures used to be kind of the gold standard. Everyone would suture. And then also using tape and just a dressing. INS specifically calls out tape and sutures and says that they avoid their use because they're not a good alternative to an ESD or engineered stabilization device. They're not as effective. They also call out VAD dressings, or vascular access device dressings. These are the non-border dressings, just the plastic adhesive dressings. Don't use those as a means of securement, stabilization. There's not enough evidence that they really do anything. What's interesting is this is a level 1 recommendation, so it's the highest level of recommendation that the INS gives out. So I strongly urge, don't just use a plastic film, a non-securement dressing as a form of securement. Now, a short little history lesson here. 1900s, natural rubber latex adhesives came out. They're still available in consumer products. They work very, very well. Problem is people get allergic to it. Latex allergies are now common day. And so came out acrylic adhesives in the 1960s. Now, acrylic adhesives are the most common adhesive in the world. They're on dressings, they're on tape, they're on electrodes, they're on armbands, they're on the window tint you put on your car. They're everywhere. The good thing about acrylic adhesives is they are very low sensitizing, and for a chemical engineer, it's like clay. You can do anything with it. You can make it to where it's more moisture resistant, more secure, more gentle. You can do a lot of things with it. It's very variable. But in the 1990s came out the development of silicone adhesives, which was a major fundamental change. Now, most of the silicone adhesives used today are used in wound care. They like the gentle adhesives on the wound sites. But there are now tapes and securement devices going into this. I suspect that just like acrylic adhesives replace natural rubber latex adhesives, in the next 10 to 20 years, everything will go to silicone. But we'll talk about some of the differences between them and why I think it'll replace it. So the first thing is to think about skin. Now here we have healthy skin, or I like to think healthy skin. This is my arm, so I'm going to say it's healthy skin, which is not your typical patient. Now, I've never been in your hospital, but I'm guessing most of your patients are older, and most of your patients are very sick. So their skin is not good. But we'll take a younger skin here. Look at it. You look at it, and it looks like you stick something to it very well. But if you start zooming in, those small little structures, the hair starts getting really big, and the natural little ridges in the skin start being exaggerated. If you zoom into the skin, it's really, really bumpy. Now that's really hard for a dressing, or tape, which is two-dimensional, flat, to stick on. So it's really a big engineering challenge to get something to stick really well. Now, on the left-hand side, we have, let's say, a typical acrylic adhesive. Left-hand side is all your typical stuff, your tapes, your dressings, your EKG lectures, whatever. On the right, silicone adhesive. Now, this is a cross-section of skin, and it naturally looks like this. It looks bumpy, it looks wavy. If I drop the acrylic adhesive onto skin, it tends to sit on the top of the skin. Silicone adhesives are more of a gel, and so they tend to mold into the skin a little bit better. You get a little bit better initial contact with adhesion. Now, with your acrylic adhesives and dressings, you're often told when they come around to educate you on how to use it, to press the dressing into the skin. What you're actually doing is squishing the adhesive on the dressing into all the little ridges on the skin, getting a greater surface contact. If you were to apply your dressing down without pressing it, you're maybe only getting 30% of the adhesion. So the more you press, the longer you press, the more aggressive it's going to stay. An odd little thing about acrylic adhesives is if you look at the adhesion profile, they take about 24 hours to fully gain their maximum adhesion potential. This is true for all your acrylic adhesives. Now, the interesting thing about this is if you can get that dressing, tape, or whatever device it is to stick for the first 24 hours without being disrupted, you're far more likely to get it to wear that full 7 days. So the first 24 hours is absolutely critical for the life of whatever that adhesive something that you're trying to get to stick. What's interesting though is silicone adhesives, since they're kind of a gel adhesive, tend to have a very, very flat adhesion. So when you first stick it down, that's pretty much what you get. It doesn't, grow an adhesion. Now, another way we can compare the adhesives is with MARCI, medical adhesive related skin injury. And when we look at MARCI, one of the things that we know is every time you remove something adhesive from the skin, you're pulling up skin cells. Now on the left is a picture of an acrylic adhesive that's been applied to skin and removed. On the right is a silicone adhesive applied to skin and removed. This test is what's known as a Confocal Microscopy study. So they put sticky things down, they peel them off, and then they use a special fluorescent dye on the skin cells, and look at it under a special microscope. And on the right-hand side, all the red are skin cells. And on the left, the skin cells are made of silicone. So the silicone adhesives tend to pull up